Let's now go into a discussion regarding some practical considerations for the quantification of pain. And as qualified medical evaluators, of course, we encounter injured workers who attempt to tell us about their injuries. And often, in interviewing your examinee, you'll find that discussion quickly devolves to a description of various painful symptoms. Pain. So, an interesting question is, for you as the evaluator, is it possible for us as examiners to be able to understand what and how the examinee is feeling in their physical body? Is it possible for us to be able to actually understand what it is and how it is that the examinee is feeling? Well, like other conundrums, and as you might have expected, the answer is both no and yes. And I say no because since pain is not something that can be felt or seen or measured by us as examiners, there really is no way to determine what the examinee is describing. And further, in my opinion, there's no way to ascertain the true presence or absence of the painful sensation that the examinee reports. So no, it's not possible. However, I also say yes, because with an understanding of some common concepts and terms, we as examiners can develop in our mind a construct of, number one, the level of pain reported by the examinee. Two, further, we can understand what is the impact of the reported pain on the ability to perform activities of daily living. And finally, with that information, we can proceed with our determination of issues in the workers' compensation arena, including permanent and stationary status, permanent impairment, causation and apportionment of permanent impairment, and other important issues as well. And all of us have experienced pain at one point or another in our lives. And all of us can agree that pain is quite worrisome and is quite a concern. So, how would you define pain? You've had pain before, doctors. How would you define pain if you were asked specifically to provide a definition for pain? Well, that might be hard to do because everybody has their own particular definition of pain. So let's go to Merriam-Webster's dictionary. Merriam-Webster says that pain is a localized physical suffering associated with a bodily disorder, such as you would find in a disease or as you would find in an injury. Webster goes on to say that pain is a basic bodily sensation induced by a noxious stimulus. It's received by naked nerve endings. It is characterized by physical discomfort such as pricking, throbbing, or aching, and typically leading to evasive action. Well, that about covers it. Simply put, pain can be thought of as an unpleasant sensory and emotional experience associated with actual tissue damage or potential tissue damage, or it is described in terms of such damage. Now, the sensory perception of tissue damage is picked up in the periphery. The emotional interpretation of the pain, that takes place in the mind. As qualified medical evaluators, our job is to identify the cause of the pain. Our job is to identify the actual tissue damage responsible for the report of pain that our examinees report. And with the multiplicity of behavioral, cultural, and gender confounders This, of course, is no easy task. So, pain, therefore, is an unpleasant sensory and emotional experience. It's associated with actual tissue damage, potential tissue damage. Sensory perception of pain is picked up in the periphery, and the emotional perception of pain is And from this point forward in this program, we explore issues related to pain, we explore issues related to symptom magnification, issues related to deception and malingering, and our goal is to provide you as a qualified medical evaluator with a practical physical examination toolkit that will provide you the information necessary to translate the subjective complaints reported by the examinee into a language that funnels down to conclusions that you can apply in the specialized setting of workers' compensation. So we're considering practical methods to quantify pain. Even though we can't see pain, we can't feel pain, how can we therefore quantify pain and translate the pain that an injured worker reports to us into language that can be used in the workers' compensation setting. So the 2001 Physician's Guide gives us some guidance here, and it answers the question, how can we attempt to quantify the pain reports that injured workers give us? Well, one practical way, one practical method is to try to determine how the pain, for example, impacts the ability to perform activities. And this is described in the 2001 Physician's Guide, and we'll explore that in just a moment. And as this idea or this concept is described in the 2001 Physician's Guide, it's my opinion also that this method is consistent also with the 2005 AMA Guides methods. And I'm going to give you a method for applying this system to injuries both before and after 1/1/2005. Although in limited use now with the adoption of the AMA Guide's 5th edition, the 1997 Permanent Disability Rating Schedule provides permanent disability for chronic permanent pain. And these are described as the subjective factors of disability. And the subjective factors of disability represent the QME examiner's professional interpretation and translation of the examinee's reports of pain into a language that can be used to determine proper benefits appropriate for the injured worker. And because your examinee's pain cannot be seen or felt, the concepts of the subjective factors of disability give the examiner one method to determine the severity of any pain by converting all of the examinee's many verbal descriptions into a quantifiable construct. And although the 1997 Permanent Disability Rating Schedule is being used less and less as time advances, and as most injuries fall under the AMA Guide's 5th edition, the description of pain used in determining the subjective factors of disability are illustrative and are still valid in giving the QME examiner an indication of the impact that the pain has on the examinee, and also allows the examiner to extrapolate those pain limitations to the more recently required analysis of activities of daily living as are required by the AMA Guides. And the 2001 Physician's Guide defines 4 levels of pain, and we'll go into each of those here now. And each of these levels of pain has a specific and defined level of impact on the ability to perform activities. So the first level of pain described is minimal pain. Following that is slight pain. Following that is moderate pain. And even worse than that is severe pain. And let's define these here now. A minimal pain, and this is according to the 2001 Physician's Guide, a minimal pain is a pain that is basically it's a nuisance. However, it produces no handicap in the performance of the activity that is reported to be the cause of the pain. Let's repeat that. Minimal pain causes no handicap in the performance of the activity that is reported to cause pain. So a minimal pain when bending over causes no handicap in bending over. There might be pain. We don't know. We can't feel pain, can't see pain. But the pain does not handicap the activity that causes the pain. Bending over is reported to cause the pain, but there's no handicap. The injured worker is able to bend over. Then there is a slight pain. Now, slight pain is a little bit more handicapping, a little bit more impairing on the activity. With slight pain, we see some handicap in the performance of the activity that is reported to cause the pain. Then we have moderate pain. Moderate pain now is more problematic. It more handicaps, or we could say it more impairs the activity that's reported to cause the pain. So if your injured worker reports pain with bending over, with moderate pain, they would have a marked handicap in the ability to bend over. Bending over might be limited, range of motion would be limited, or it might be guarded and slow, and other examples of handicapped bending. And we'll go into some of those as we progress here. Then we have severe pain, and the 2001 Physician's Guide says that severe pain precludes the activity that's reported to be the cause of the pain. And we'll give some examples of what severe pain would look like here also as. Okay, so let's talk about minimal pain. Minimal pain. Now, let me give you a recommendation. Never tell an injured worker or any other person who tells you about pain, never tell them that the pain that they're experiencing is minimal. Of course, that's going to get you beat up, and that's not going to go over well, because there's no way that you can ever tell anyone that the terrible pain, the excruciating pain, the crushing pain, the stabbing pain, the blinding pain, the vicious pain that they're experiencing and that they're describing to you is minimal pain. And if you've ever tried to explain your pain to someone, when you're having pain, it's never minimal pain. So never try and tell someone that the pain that they're having is minimal. And you're probably familiar with this phenomenon. Whenever you're explaining to someone about your pain, or whenever anyone explains to you about their pain, sometimes in order to help others to feel what we're feeling and to experience what we're experiencing, and to give them an indication as to the suffering and the distress that we're going through, all descriptions of pain default to terrible, to excruciating, and to severe. And you can probably relate to this. Certainly any man who's suffered a back strain or a flu will attest to these descriptions. You lay there on the couch, you moan for everyone to hear, and you're just hoping in your suffering that someone will bring you a bowl of chicken soup and a blanket. Right? Oh, sure. When it happens to you, pain is terrible. It's excruciating. And husbands and wives will agree to this description. However, no matter how terrible pain may be described, most pain that we encounter is actually quote-unquote minimal pain, because consistent with the definition found in the 2001 Physician's Guide, minimal pain does not cause handicap in the performance of the activity that causes the pain. And a couple of examples of minimal pain will illustrate this. And we'll talk about a basketball player in a non-industrial setting, and then we'll talk about an injured worker in the industrial setting. So this is an example of minimal pain. Consider a basketball player. A basketball player comes off the court at halftime, and he tells the team trainer that my knees are killing me. This is what he says. My knees are killing me. But in the second half of the game, this same player goes out on the court and he scores 20 points and he gets 10 rebounds. Now, what do we know in this scenario? Do we know if the player actually has pain in his knees? Do we know that? Well, the answer is no. We do not know. We don't know. We can't see his pain. We can't feel his pain. We don't know if he has pain in his knees or not. All we can do as an observer in this case is to observe the player and look for manifestations of the impact of the pain on his ability to perform. In this case, we're not looking at the ability to perform activities of daily living, but rather we're looking at the ability to perform on the basketball court. In other words, we observe for outward, objective, visible impact of the reported pain on his ability to run up and down the court, to jump, to pivot, to twist, to turn, and basically to be a basketball player in full unrestricted form. And in this example, because he scores 20 points and he gets 10 rebounds in the second half of the game, we don't see any outward, objective, visible impact of the pain on the ability to play basketball. The player runs up and down the court at full speed. He stops, he starts, he jumps, he fights for rebounds, he shoots, he scores. I think you get the point. This is minimal pain, because the pain that he reports in his knees, no matter how bad it may seem to him to be, remember he said it's killing me, his knees are killing me. No matter how bad it may seem to him to be, the pain causes no handicap in the performance of the activity that's reported to cause the pain. In this case, the activity is playing basketball. That's minimal pain. Okay, how about an injured worker in the industrial setting? Okay, imagine you're conducting a QME examination, and an examinee tells you about pain in his left shoulder joint. The examinee tells you, for example, he says, I don't know what's wrong with my shoulder, but when I raise my arm like this, and he demonstrates by raising his arm overhead, he says, I get a sharp pain in my shoulder. It feels like an ice pick in the center of the joint. Now, what do we know in this scenario? Do we know if there's pain in the shoulder? No, we don't know. We cannot see the pain. We cannot feel the pain. We don't know if there's pain in the shoulder or not. What we do as astute observers is to look for manifestations of the impact of the reported pain on the ability to perform the activity that causes the pain. In this case, the activity is reaching overhead. He said that when he raises his arm overhead, he gets a sharp ice pick pain in the center of the joint. And we don't see any impact of the pain on the ability to raise the arm overhead. We don't see any grimace. We don't see a painful arc. We don't hear any joint crepitus. We don't see any apprehension. The arm goes completely up and overhead to 180 degrees of shoulder flexion or abduction. This is minimal pain. This is minimal pain because the pain that he reports in the shoulder, no matter how bad it may seem to him to be, it causes no handicap in the performance of the activity that's reported to cause the pain. In this case, the activity is raising the arm overhead. What about slight pain? Occasionally you'll see examples of slight pain where the pain causes some handicap in the performance of the activity that's reported to be the cause of the pain. This means that the pain disadvantages the activity that causes the pain. So what qualifies as some handicap, quote unquote, some handicap? The definition of slight pain is that the pain causes some handicap. So, in your opinion, doctors, what qualifies as some handicap? Well, this is open to differing interpretations, but the handicap or the disadvantage, whatever it may be, should be accompanied by an outward, visible, objective, quantifiable alteration in the performance. And let's just go over our examples again of a basketball player in a non-industrial setting and an injured worker in an industrial setting. And we're talking now here about slight pain. With slight pain, a basketball player, for example, comes off the court at halftime again, and he tells his team trainer, same thing, he says, "My knees are killing me." Now, this time, this is not new news to the trainer because throughout the game, the player was observed to be able to run at only 3/4 speed up and down the court. He was observed to have a shortened stride length when running. On several occasions, he was observed to hang out at midcourt rather than running deep into either the offensive or defensive zones. In the training room at halftime, the trainer observed slight retropatellar effusion bilaterally. The right knee was painful in full passive extension, and for comfort, the player rested the knee in 15 degrees of flexion. What do we know in this scenario? Well, we know that the pain is more than minimal because we see outward objective indications of the impact that the pain has on the ability to perform. We see objective indications of handicap in the performance of playing basketball. Can he still play? Yes, he can still play. He can play as long as he and the coach agree that his ability to perform is a benefit to the team and not a threat to his health. And now the key criteria in this example are the presence of 1, objective outward sign of handicap in the performance of the activity, and 2, objective physical examination findings. We have here findings. We have findings on handicap, and we have findings on objective physical examination. Now, what about an injured worker in the industrial setting? Well, let's follow our injured worker with the painful left shoulder. So again, our examinee in this case tells us about pain in his left shoulder joint. He says, same thing that he said to you before. He says, "I don't know what's wrong with my shoulder, but when I raise my arm like this and he demonstrates by raising his arm overhead. He says, I get a sharp pain in my shoulder. And it feels like an ice pick in the center of my shoulder joint. And on observing the examinee to bring his arm overhead, we note a painful arc between 80 and 120 degrees of abduction. At 80 degrees, the examinee quickly brings the elbow in close to the body, and with the arm hugging close to the body, he slowly raises the arm overhead. Nearing full abduction, we hear a sharp pop from the glenohumeral joint. The examinee lowers the arm the same way by bringing the arm down close to the body and slowly returning the arm to the side. On physical examination, we note a positive sulcus sign and a positive apprehension maneuver. What do we know in this scenario? Well, we know that pain is more than minimal because we see outward, objective indications of the impact that the pain has on the ability to raise the arm overhead. We see objective indications of handicap in the performance of shoulder abduction. Can he still raise the arm overhead? Yes, he can still raise the arm overhead. However, the maneuver is modified, it's changed, it's altered, it's limited, or it's handicapped in some way that's objective, it's visible, it's verifiable, and it's repeatable. Key criteria in this example are the presence of 1. Objective outward sign of handicap in the performance of the activity, and 2. Objective physical examination findings. Again, objective findings of handicap and objective physical examination findings. What about moderate pain? Well, many examinees in the workers' compensation system and people in general, they'll report to you that their pain is moderate. And they report moderate pain because they're not aware, of course, of the definition of this term as it's used in workers' compensation, and that's normal. And so they use the word moderate. And moderate is a description that can be safely used by the layperson because it does not appear to be overly exaggerated. For example, it's not severe, it's not excruciating, it's not awful. And it's a credible description because it leaves room for situations where other people could have worse pain. However, true moderate pain is rare. By definition, moderate pain is a pain that causes a marked handicap in the performance of the activity that causes the pain. So, what would qualify as a marked handicap? Well, a marked handicap would be obvious and plain for all to see. And to continue our examples of pain, let's consider the basketball player and the injured worker again in the non-industrial and industrial settings. So our basketball player comes off the court and he tells the trainer, my knees are killing me. And this is not new news to the trainer because earlier in the game, the player was involved in a collision that caused him to come down on the floor with his feet out from under him. And he landed directly on his patellae, both patella. He lay on the ground writhing in pain as the team took a 2-minute timeout. After being helped to his feet by his teammate, he started to slowly walk around with a noticeable limp on the right. After making one of 2 free throws, he was noted to not be able to run. Another timeout was taken and the player was removed from the court, walking off with the help of 2 team trainers. Now, what do we know in this scenario? Well, we know that pain, with its inhibitory effect on alpha motor neurons, has taken away this player's strength in the legs, or for any activity that requires the application of strength through the knees. This pain causes a marked handicap in the activity that causes the pain. In this scenario, the activity is not the larger activity of being able to play basketball. No. Now, the activity is much more limited and much more handicapped. Now the activity reduces to the ability simply to operate the legs, to be able to operate the legs, the ability to walk, the ability to stand, the ability to flex and extend the knee, the ability to apply pressure to the foot. See, this is a much more limited scope of activity than the multiple complex and compound movements involved in playing high-level basketball. Now we're talking simply about the ability to bear weight and to walk and to stand. See, this is moderate pain. Can the player bear weight? Can he walk? Yes. He can bear weight, he can walk, but just barely. Just barely. In this example, neurologic inhibition due to nociception causes a marked handicap in the activity, and this is plain for all to see. And objective physical examination findings are readily evident. What about our injured worker in the industrial setting? Our examinee again tells us about his left shoulder pain. He tells you, I can't raise my arm above my shoulder. I can move it down by my waist, but not above my shoulder. On observation, you note that as the examinee raises the arm in abduction, at 60 degrees of abduction, his face winces terribly, and the arm drops down 15 degrees to about 45 degrees of abduction. You ask the examinee, what happened? He replies, I don't know. I just got a sharp pain and I can't lift it. You ask him, I see. But even though there is pain, can you lift it? He tries again and again, and the same result happens. He gets a sharp pain at 60 degrees of abduction. You believe that he genuinely cannot lift the arm above 60 degrees of abduction. In this example, pain inhibition due to nociception causes a marked handicap in the activity, and this is plain to see. There's still some movement at the shoulder. For example, shoulder extension is preserved, shoulder internal rotation is preserved, but at least for the movement of shoulder abduction, we conclude that pain causes a marked handicap in the ability to perform shoulder abduction. Handicap is not quote-unquote complete because there's still approximately 60 degrees of abduction left. There is not total loss of abduction, but the majority of abduction is not possible, and objective physical examination findings are readily evident. And finally, what about severe pain? Well, we rarely see examinees in severe pain because severe pain is more seen in the acute setting than in the chronic setting, such as we see injured workers for their QME examinations. And people who are in severe pain usually find themselves in the emergency department of hospitals, and they're found on gurneys. Okay, that's severe pain. We don't see examinees walking into their QME appointments in severe pain. Now, how would severe pain appear in the example of the basketball player? Well, according to the definition, severe pain is pain that precludes the activity causing the pain. Well, what's the activity of the knees? The activities of the knees are to bend, to bear weight, to walk, and to squat, among other things. In the presence of severe pain, the player would be required to use crutches or a wheelchair due to preclusion from weight bearing. And what about the example of the shoulder pain in our injured worker? Well, severe pain, severe shoulder pain, would require that the arm hang limply from the side, perhaps in a sling with no motion. And in both examples of the basketball player and the injured worker, the physical examination would be obvious for objective findings of a conclusion of severe pain. So let's review these definitions of pain. A minimal pain causes no handicap in the performance of activity. A slight pain causes some handicap in the performance of the activity. Moderate pain causes a marked handicap in the performance of activity. And a severe pain would preclude the activity. And you would see also a progression in your objective observations and also in your objective physical examination findings as you progress down the scale from minimal